Finals SAQ69, Brain Death and Organ Donation. A 20-year-old patient who satisfies the criteria for brainstem death has been accepted as an organ donor. A. List the main adverse cardiovascular changes associated with brainstem death. Sequentially, brainstem ischemia, followed by massive sympathetic outflow due to brainstem herniation, leading to hypertension, tachycardia, increased SVR, increased pulmonary vascular resistance, reflex baroreceptor-mediated bradycardia, myocardial dysfunction, organ vasoconstriction, impaired perfusion, tissue ischemia, and ischemia-reperfusion injuries, progression of brainstem ischemia and infarction with foramen magnum herniation leads to loss of vasomotor centers, autonomic collapse, reduced spinal cord sympathetic outflow, leading to reduced cardiac output, hypotension, atropine-resistant bradycardia, and circulatory collapse. Vasodilation, bradycardia, and asystole finally occurs. Ischemia of the pituitary leads to pituitary failure, which exacerbates shock. Intravascular depletion contributes to cardiovascular instability. B. What are the physiological goals required to ensure optimization of this donor? These include PaO2 of more than 75 mmHg, PaCO2 of 37 to 48 mmHg, pH of more than 7.25, MAP of 60 to 80 mmHg, CVP of 4 to 10 mmHg, cardiac index greater than 2.1 liters per minute per meter square, central venous oxygen saturation more than 60%, SVRI of 1800 to 2400, temperature of 36 to 37.5 Celsius, blood glucose of 4 to 10 millimoles per liter, plasma sodium less than 150 millimoles per liter, and urine output 0.5 to 2 mL per kg per hour. C. Outline the measures and drugs that may be used to achieve these goals. Respiratory. Measures include lung recruitment maneuvers, lung protective ventilation strategy, ideally keep FiO2 below 0.4, 30 to 45 degree head-up positioning, ensure adequate ETT cuff inflation, regular position changing, regular chest physio and suction, consider bronchoscopy, bronchial lavage, and toilet for therapeutic purpose when available. Cardiovascular. Central venous access should be via right internal jugular vein due to early ligation of left innominate vein. Left radial arterial line is preferred due to early ligation of right subclavian artery. Cardiac output and flow monitoring and urine output monitoring to guide fluid management, ensure euvolemia, avoid excess fluids. Commence vasopressin if vasopressor is required. Wean or stop catecholamine presses as able. Commence dopamine or dobutamine if goals are not met with vasopressin. Endocrine. Hormone therapy may help stabilize donors hemodynamically and extend the donor pool once pituitary failure ensues. Follow local protocols. Drugs involved in hormone replacement therapy includes methylprednisolone 15 mg per kg, insulin infusion, desmopressin or vasopressin, and triiodothyronine. Fluids. Review fluid administration. Provide IV crystalloid maintenance fluid to maintain sodium less than 150 millimoles per liter. Continue nasogastric feeding unless advised otherwise. Hematological. Physical and pharmacological prophylaxis of thromboembolism. Correct coagulopathy if present. Metabolic. Maintain normothermia and correct hypernatremia. Monitoring and investigations. Hourly observations as per critical care policy. 12-lead ECG to exclude Q waves. Chest X-ray post-recruitment procedure where possible. Troponin levels in all cardiac arrest cases with follow-up samples. Echocardiogram where available. Review and stop all unnecessary medications. Overall, 68.8% pass rate. The NHS Blood and Transplant has an extended care bundle included here for management of patients who are donors after brainstem death. Additional Q&A. Discuss the concept of consciousness and various causes of altered consciousness. Consciousness is a state of awareness of self and one's relationship to the environment. Components of consciousness includes awareness and arousal. Awareness refers to the ability to understand one's relationship to one's surrounding. Attentiveness is the degree of awareness. Arousal is ability to experience one's surroundings and is characterized by wakefulness and alertness. Awareness depends on integrity of connections between the cerebral cortex and subcortical white matter, while arousal is mediated by the ascending reticular activating system. Altered states of consciousness includes anxiety or lethargy, whereby awareness is intact. Attentiveness is increased in anxiety and reduced in lethargy. Locked-in state, arousal and awareness are intact, but there is almost total absence of motor responsiveness. In delirium and dementia, arousal is intact. Awareness is fluctuating in delirium and is slowly progressively deteriorating in dementia. In vegetative state, some degree of arousal is present, but awareness is not present. Movements are purposeless. Persistent vegetative state refers to vegetative state persisting for more than 1 month. In coma, this is a state of total absence of arousal and awareness. Movements, if present, are purposeless. In brain death, there is total absence of arousal and awareness. Brain death differs from coma, as there is loss of all brainstem function in brain death, including cranial nerve activity and spontaneous respirations, and brain death is always irreversible. This table compares the various causes of altered consciousness with the results of function tested, purposeful response to stimuli, behavioral arousal and sleep-wake cycles, brainstem reflexes, and spinal cord reflexes. Causes of altered consciousness may be divided into structural causes and toxic metabolic causes. Examples of structural causes include trauma, leading to hematoma, parenchymal hemorrhage, or diffuse axonal injury, neurovascular causes such as intracerebral hemorrhage and ischemic stroke, CNS infections, neuroinflammatory disorders, neoplasms, seizures, and others such as PRES, osmotic demyelination, and anoxic ischemic encephalopathy. Toxic metabolic causes includes metabolic encephalopathies such as hypoglycemia, hypoxia, hypercapnia, DKA, hyperosmolar non-ketotic hyperglycemia, hepatic encephalopathy, uremia, hyponatremia, hypernatremia, mixed edema, thyrotoxicosis, adrenal failure, hypercalcemia, Wernicke's disease, and sepsis. Drug or medication overdose can cause altered consciousness, such as due to drugs of abuse, sedatives, narcotics, aspirin, paracetamol, antidepressants, antipsychotics, and anticonvulsants. Environmental causes include heat stroke, hypothermia, and carbon monoxide poisoning. Selected conditions that alter pupil size and their reactivity in patients with altered consciousness are included here. What are the 4 steps involved in the neurologic assessment of the unconscious patient? These include determine the level of consciousness, followed by assessing brainstem reflexes, evaluating motor responses, and examining breathing patterns. What are the methods in determining level of consciousness? This includes GCS, AVPU, and the 4 score. The scoring for GCS is included here. GCS is used to categorize severity of TBI, to guide ICP monitoring, used to determine the need for CT head in TBI, to determine whether to intubate the patient. It is used in Apache 2 score, and is used to monitor the depth of coma. Advantages includes it is widely recognized, has face validity, quick, reproducible, helps to assess severity of TBI via motor score, and correlates with neurological outcomes. Disadvantages includes problems with the use of GCS. The component scores are more important than the total score. It does not incorporate brainstem reflexes. The M score does not factor in unilateral pathology. It is unreliable in patients with middle range of 9 to 12 score, and it does not accurately predict outcomes in individual patients. Problems with performing GCS. It is difficult for untrained staff to apply properly. There is variation in scoring of the V-score in intubated patients. It is subject to language barriers. It cannot be applied to small children. It may be affected by other factors influencing the level of consciousness, such as drugs. The use of GCS in intoxication is unvalidated, and there are debates in literature when GCS can be first applied after TBI. Problems with accuracy and validity of GCS. There is poor inter-observer reliability. Reproducibility is poor. There are other neurological scoring systems that have demonstrated similar or greater validity and reliability, and GCS of 8 does not reliably correlate with the presence or absence of airway reflexes. Other scoring systems includes the AVPU score, where A stands for alert, V for verbally responsive, P for painfully responsive, and U for unresponsive. The components and scoring for the 4 score is included here, which includes the eye response, motor response, brainstem reflexes, and respiration. Describe how would one manage a comatose patient. Immediate approach to the comatose patient includes measures to protect the brain by providing adequate cerebral blood flow and oxygenation, reversing metabolic derangements, and treating potential infections and anatomic or endocrine abnormalities. Ensure that the patient has patent and protected airway and adequate breathing. Supplemental oxygen should be administered and airway secured by intubation if needed. Vascular access should be obtained, hypotension corrected with fluids and vasopressors as required. Blood samples should be obtained to rule out infection, metabolic or endocrine abnormalities. Generalized seizures should be treated and metabolic abnormalities corrected. If the cause of coma is uncertain, consider administering D50, thymine, naloxone, and flumazenil as appropriate. If increased ICP with mass effect is suspected, provide mannitol, hypertonic saline, and possibly hyperventilation as a bridge to specific neurological decompression. If meningitis is suspected, provide antibiotics. Perform CT scan to rule out mass effect or herniation, in combination with laboratory evaluation for coagulopathy or thrombocytopenia prior to lumbar puncture. An emergent non-contrast head CT should be obtained for unconscious patients with a structural cause of coma, or for patients without a clear cause of coma following initial evaluation. CT scan can identify intracranial hemorrhage, brain masses compressing midline arousal pathways, cerebral edema, hydrocephalus, and cerebral infarction. Following the initial workup and stabilization of the comatose patient, they should be admitted to a specialized critical care unit for supportive care to maximize the chances of recovery. Cardiorespiratory support should be maintained as appropriate, with attention to maintenance of cerebral oxygenation. Measures to prevent ventilator-associated pneumonia should be performed. Electrolytes should be monitored closely and replaced as required. Early initiation of full enteral nutrition whenever possible. Other essential steps includes measures to reduce the risk of infection, gastric ulcer prevention, thromboembolism prevention, physical therapy, splinting when appropriate, and skin care for pressure ulcer prevention. Early tracheostomy may be considered if prolonged mechanical ventilation is anticipated. Brain death testing may be considered at least 6 hours after the onset of an apneic coma, 24 hours after restoration of circulation if the cause was a cardiac arrest, and at least 24 hours after the restoration of normothermia if therapeutic hypothermia was used. Define death and brain death. The Uniform Determination of Death Act states that death occurs when an individual has sustained either irreversible cessation of circulatory and respiratory functions or irreversible cessation of all functions of the entire brain, including brainstem. Brain death describes the situation in which a patient has undergone the irreversible loss of any capacity for consciousness, together with irreversible loss of the ability to breathe. Essential components of brain death includes irreversible coma, absence of brainstem reflexes, and absence of spontaneous respirations during a CO2 challenge, i.e. apnea test. What are the steps in performing brain death testing? First, ensure the preconditions for brain death testing are met, which includes a definitive diagnosis of cause of coma, which is sufficient to account for irreversible brain death, apneic coma with a GCS of 3, core body temperature of more than 36 degrees Celsius. There should be no residual CNS depressant drugs in the patient's body. Adequate time for clearance should be ensured. There should be no neuromuscular blockade, which is excluded by peripheral nerve stimulator. There should be no endocrine or metabolic disturbance that may contribute to continued coma. Normal glycemia, normal thyroid and adrenal function should be confirmed. There should be no impaired circulatory function and shock. Systolic blood pressure should be more than 100 mmHg. There should be normal capnia and absence of hypoxia. Brain death tests aim to confirm the absence of brainstem reflexes and examine cranial nerves which are amenable to testing. 2 sets of brain death tests are usually performed. Although there is no set interval between them, they are usually done a few hours apart. The performer of brain death tests should be made by 2 medical practitioners trained and experienced in the field, where both doctors have been registered for more than 5 years, one of whom must be a consultant, and neither should be a member of the transplant team. There has never been a reported case of a patient who initially satisfied the criteria for brainstem death and who subsequently failed to do so. A brain death certification checklist example is included here. The following cranial nerves are tested in brain death testing. Cranial nerve 1 is not tested. Cranial nerve 2 is tested via pupillary light reflex. Cranial nerve 3, 4, 6, and 8 are tested using the oculocephalic reflex and the oculovestibular reflex. Cranial nerves 5 and 7 are tested via the corneal reflex and response to painful stimuli applied to the face, limbs, and trunk. Cranial nerves 9 and 10 are tested via gag and cough reflex. Cranial nerves 11 and 12 are not tested. The apnea test is done the last after all the above reflexes are absent to avoid unnecessary hypercapnia should any of the other reflexes be present. The steps to perform apnea test are included here for completion. Describe some ancillary tests for the diagnosis of brain death. Ancillary tests for the diagnosis of brain death includes that to confirm the lack of circulation to the brain, such as cerebral scintigraphy, CTA, transcranial Doppler, and MRA. A flat EEG is consistent with brain death. Absence of evoked potentials, such as auditory, visual, and somatosensory evoked potentials, is consistent with brain death. These tests are typically used when the neurologic examination is equivocal and full brain death examination is not possible. Disadvantages of these tests includes there is insufficient evidence to determine if they can reliably identify brain death. Brain death remains a clinical diagnosis, and no ancillary test can replace a clinical determination of brain death. No blood tests exist currently that can help establish brain death. There is no requirement for a particular neuroimaging modality to diagnose brain death. What are some potential pitfalls in brain death testing? There should be no pitfalls if the preconditions are fully satisfied, and brain death tests are performed with scrupulous care. Death is confirmed after the second set of brain death tests, and the time of death is recorded as the completion of the first set of brainstem death criteria. Movements that may exist in brain dead patients includes spinally mediated reflexes and automatisms, and other movements such as spontaneous movements of the head, torso, upper extremities, facial myokemia, transient bilateral finger tremor, repetitive leg movements, ocular microtremor, and cyclic constriction and dilation of light fixed pupils. Many patients retain plantar reflexes. Lesions which may mimic brain death includes severe Guillain-Barré and Miller-Fisher syndromes, Bickerstaff's brainstem encephalitis, and ventral pontine infarction associated with lock-in syndrome. Brain dead patients can falsely trigger delivery of breaths on ventilators. Formal apnea testing may be required to exclude confounding factors. Regarding children, the CNS immaturity in neonates raises doubts about the validity of brainstem testing in this population, and there are anecdotal evidence of children who have recovered substantial neurological function despite severe neurological insult and prolonged coma. What are the contraindications for organ donation? This includes a transmissible infectious disease that will adversely affect the recipient, recent malignancy, and clinical signs that indicate the organ is unlikely to function. What are the pathophysiological changes during and after brain death? CVS changes has been discussed in the prior section. Respiratory failure occurs, which may be due to pre-existing pulmonary disease, neurogenic pulmonary edema, or acute lung injury. Endocrine changes includes hyperglycemia due to reduced insulin and increased insulin resistance. Pituitary failure leads to reduced ADH, which causes diabetes insipidus. Reduced ACTH leads to hypocortisolism. Reduced TSH leads to hypothyroidism. Serum electrolyte abnormalities includes hypernatremia, hypermagnesemia, hypokalemia, hypophosphatemia, and hypocalcemia. Lactic acidosis due to shock. Hypothermia due to loss of temperature regulation from hypothalamic dysfunction. Systemic inflammation and oxidant stress occurs. Coagulopathy may be present due to release of tissue fibrinolytic agents and plasminogen activators from the necrotic brain. Describe the conduct of anesthesia for the brain-dead organ donor. Donor organs are procured, usually from long midline incision and median sternotomy. Duration of procedure is up to 6 hours. Pain control is not applicable. Patient position is supine. Expect large fluid losses and blood loss. Anesthetic technique is IPPV, CVP, and Artline. Providence of general anesthesia is controversial. However, muscle relaxants may be still required to prevent spinal reflexes. Pre-op preparations. Confirmed brain death and agreement for organ donation. Emphasis shifts from cerebral resuscitation to optimizing organ perfusion and oxygenation. Ideal donor characteristics for ideal heart donor, ideal lung donor, ideal donor for recipients with pulmonary hypertension are included here. HLA type and ABO blood group should be compatible. Target physiological parameters for organ retrieval and measures and drugs that can be used to achieve these physiological parameters have been discussed in the previous section. Anesthetic setup for organ procurement, equipment and supplies, ventilator as in ICU, standby bronchoscope, warming blankets, blood warmers and ice. Recheck items includes declaration of death, cause of death, consent and blood type. Prepare lactated ringers, albumin and blood products. Medications to prepare includes vasopressors, antibiotics, neuromuscular blockers, heparin, corticosteroids, povidone iodine, NAC, insulin, mannitol, furosemide, and PGE1. Perioperative management. Anesthetic management during organ procurement is guided by the needs of the procurement team. They may come from various centers and may have discrepant requests. Standard monitoring plus CVP, intraarterial blood pressure monitoring, core temperature, urine output, and frequent analysis of ABGs, electrolytes, hematocrit, glucose, and clotting. Large bore IV access at right upper limb. CVL via right internal jugular vein is preferred. Artline at left radial artery. Replace fluid losses with crystalloid, colloids, or blood products. Fluid losses may be up to 8 liters. Target physiological parameters for organ retrieval should be maintained. The need for general anesthesia is controversial. Options to control reflex pressure responses during surgery includes up to 1 mg isoflurane, fentanyl 5 to 7 micrograms per kg, labetalol, and GTN. Administer cardiostable non-depolarizing neuromuscular blockers such as pancuronium or vacuronium to obtain spinal reflex muscular contractions. Provide lung protective ventilation. The surgeon will perform bronchoscopy prior to lung removal, and the following may be requested: glucocorticoids and ipoprostenol. Ipoprostenol improves circulation of the lung preservation solution. Maintain hemodynamic stability with colloids, IVI vasopressin, metaraminol, and other pressors. Hemodynamic fluctuations may occur due to compression on the IVC, manipulation of the adrenals, and blood and fluid loss. Mannitol and loop diuretics may be required just prior to collection of donor lungs. Full heparinization is usually administered centrally prior to surgical cannulation of major vessels. To reduce the incidence of emboli found within retrieved organs, broad-spectrum antibiotics can lower the risk of post-transplant infection. Withdrawal of the PAFC or central venous line should be done before the ligation of the SVC. Organ ischemic time should be minimized. Note down the time of aortic cross-clamp as the beginning of organ ischemic time. After completion of the procedure, discontinue life support. Discontinue mechanical ventilation and monitoring. Remove the endotracheal tube after lung inflation and tracheal cross-clamp, while the abdominal surgical team continues to operate in circulatory arrest. These are my references. Thank you.